and he also happens to be the academic director for the Behavioral Implementation Science Intervention Center at the National University of Singapore. He's also the specialty chief editor for Frontiers in Health Services for the Implementation Science section. He has a vision to achieve population health and high quality healthcare delivery through the application of psychological and behavioral sciences and partnership development between stakeholders in the academia, health services, charitable organizations, and industry. He has over 450 publications to date, and his publications are mainly in this research area, which is interdisciplinary space of implementation and improvement sciences and applied psychology. So with this brief introduction, I'd like to welcome Nick to take it from here. Welcome, Nick.
Tanya, thank you. That's a very kind introduction. It's very kind of you to be hosting me in your webinar series. So good evening from Singapore, which is about 9 minutes past 10 o'clock in the evening. But the beauty of technology, although it gave us a bit of a glitch to begin with. So apologies for that delay because I could not log in, but now I can. So thank you all for coming. And again, thanks, Tonya, and the organizers, to the organizers for having me. So let me see if I can share my screen. Okay. It's telling me that you can see this. If you can't, just shout out. But Tonya, fantastic. Thank you very much. So I understand we now have about 50 minutes or so. So I will probably keep you busy presenting some slides to sort of share some of my personal experience with implementing interventions that have a reasonable evidence base into practice and expecting to see a result. And by result, I mean an improvement in a patient outcome or in the way we deliver healthcare in a particular pathway. And what happens when this is not the case? What can we do to actually shift those improvements into routine clinical practice? So this is essentially what we're talking about today. And this is what the field that's in the last 15 years or so has become known as the field of implementation science, is really what the focus of my talk is. This is what I'm doing for a living. So just so you know who's talking to you. So as Tonya very kindly introduced me, I'm a psychologist by training. For the last 20 years, I've been working in healthcare environments, looking at, first of all, what we can do to improve the way complex interventions are delivered, typically by healthcare teams, how we can get teams to work better together, how do we use checklists and other methods of enhancing communication, improving communication within teams and leadership and so on. And increasingly, in the last sort of 10 years, I've shifted from developing those interventions to studying how we can implement them more or better. Because what you often have is interventions that have reasonable evidence behind them. They get published in academic journals. They get presented at academic conferences, in my experience. And then when you look at daily practice, it sort of lags behind. And my sort of question for the last 10 years or so has been, well, why is that the case? And can we do something to overcome this gap? So today I'm really in communicating with Tonya about this webinar. I said that it might be useful to present the basic elements that form what we now call the science of implementation in the context of health and healthcare intervention. So I aim to do this in the next sort of few minutes, and then we'll have hopefully at least 15 or 20 minutes to talk about how this relates to your work and whether this is something that you find relevant and of interest. So this is really what we're trying to do tonight or today in this webinar. So the reason we're here today, essentially, the reason I'm in a job and I'm now based full-time in Singapore for the last year or so. Before that, I spent 2.5 decades in England. So I was working in various universities in London, the wider London area. We're doing quite a lot of work with people internationally. including colleagues on in your part of the world. By your part, I mean Africa, but fortunately not where you guys are based. And likewise, I hadn't worked in Asia before I moved to Singapore. The reason this cartoon sort of exemplifies why we're here today. So there is tons of research coming out, typically from large academic clinical centers in big Western healthcare economies. Typically, the US produces tons of that research, but then some European countries produce the same, and then you have increasingly, the new and upcoming centers, or when I say centers, concentrations of research. We have a huge amount of clinical evidence coming from Chinese universities and research centers these days, and that sort of exemplifies where the world's going. But the whole point is that all of us, no matter what your specialty is, could be surgery or whatever type of surgery, whatever subspecialty of surgery, could be internal medicine, could be psychiatry, could be clinical psychology, it doesn't really matter. We're drowning in research. And that's the point. We can't follow the amount of research that is being published. Our colleagues who work in bioinformatics are trying to develop ways to allow us to digest the vast amount of research that is going on. It's just inconceivable. And humanly, it's not possible to absorb all of that research and filter it through to see what applies to your hospital or my hospital or our patients or our services. It's a huge amount of research, but it's not utilized in full. It's so much, but is underutilized. And of course, this is a bit of a problem because we're spending a lot of money to produce the research and a lot of effort and a lot of energy. So what happens to it? So here's my personal story. For those of you, and I assume the audience comes from a range of clinical specialities. One of the major drivers for me getting into this area of studying implementation processes was this intervention, which is the World Health Organization surgical safety checklist. That goes back almost 15 years now, was developed and published in 2009. Of course, the development happened before that. It was developed by clinicians. The whole point of this was, what can we do in both developed and developing healthcare systems to ensure the absolute basic safety checks before a patient undergoes surgery? And essentially, the idea was, for those of you who are not in surgery, before you put the patient to sleep, that's the left side of the checklist, let's just check their name, they haven't got any allergies, what procedure they think they're having, and all of that. The middle bit is when the patient is asleep, but before the procedure has started. So everybody gets together again. So you have an anesthetist or an anesthesiologist. You have nurses or scrub technicians, no matter how you call these professions, they're usually around. And of course, you have surgeons, and they talk about, have we given antibiotics as we should? Because WHO suggests that we need to do that within 60 or 90 minutes, depending on the antibiotic or incision. Have we got bloods in case we need to transfuse? What are we doing to this patient? Very basic stuff. What's the procedure? What's the side of the procedure? Because it's left or right, and so on. And when you finish, you've got the final bit on the right, which is, what have we just done? Have we taken any specimens? Have we sent them to the lab? Are we doing a surgical instrument count? Is that count correct to make sure there's nothing left inside the surgical and abdominal cavity, for example, and so on? So a really simple intervention, because this is all it is. Like, that's the intervention. There's nothing more than that. It's one page. The idea is that people do it before anesthesia, before surgery, and when surgery is completed. It's inexpensive. People liked it. Clinicians like yourselves developed it. It wasn't done by any manager or a health economist or anybody else. And studies starting appearing showing that this intervention, there was a major study in 2009, the New England Journal, not a very well-designed study, but a very well-publicized study that showed that mortality went down, complication rates went down. So all of the standard, a very lengthy list of surgical complications was reduced because people did the checks, and obviously they acted on those checks. And then one large-scale randomized trial was done. I had the pleasure of being involved in that. That was in Norway, and that's the paper on the bottom right of the screen. And then there's review after review, and we sort of summarized in a high-level review a couple of years back the evidence base, and we made the point that there is no point doing any more randomized trials. We don't need randomized trials. We know this thing works. Even in the randomized trial, the mortality was not affected, but morbidity was reduced, length of stay was reduced. So essentially, this resulted in financial savings as well in the hospitals where we trialed it. So there's as much evidence as you would want for a relatively simple intervention that's literally fits on one piece of paper. And the idea was that all the hospitals around the world, no matter what's your financial constraint should be able to use it, and we know it works. So it's sort of, and a lot of people, when you talk to them about it, and I remember talking to friends of mine where all this was happening in 2007, 2008, 2009, they were saying, well, that's a good idea, because when I go through a procedure, these were surgeons or anesthesiologists, I think through some of these checks in my head anyway. So essentially what this thing does, it formalizes what I'm doing in my head. Just make sure that everybody's doing it, more junior members of a team are doing it, we all communicate. So it was a general feeling that this was a good idea. But then you have this study appearing a bit later, which is the largest study, is essentially an implementation study, although they didn't call it that. They did a pre and post checklist implementation comparison of surgical mortality and surgical morbidity in the province of Ontario in Canada. Canada is a massive, huge country. Ontario is a massive, huge province, and many countries, Singapore is a great example, they would fit many times over within Ontario. It's a huge study, 215,000 patients. Of course, they didn't go to see what was going on in those operations. They downloaded the data because they had electronic health records, so they could see the outcomes of patients before the checklist, the outcomes of the patients after the checklist was introduced, and they did all the relevant risk adjustments. So they want to make sure that the patients are not sicker or less sick before or after, because obviously that's the bias. So they've done all of this, well-designed statistically, this study, and you look at the data, and it's the exact same figures, like no change whatsoever. It doesn't really matter if you use the checklist or not. So this pattern of results seem to be flying to the face of the evidence that we had up until that point. But interestingly enough, when you read this paper, there was, because the paper generated quite a lot of interest, there was quite a lot of commentary. And interestingly, one of these comments, which I have here for you verbatim, this is literally taken out of the paper, was written by a very senior surgeon, an American surgeon, who basically said, based on his own experience, that he felt the likely reason for the lack of effectiveness was the fact that the checklist was not being used. And of course, the computer system cannot tell you that, right? The computer system will only tell you what's on it. But in his experience, the checklist was, in theory, meant to be in place, but in practice, it wasn't used. So then we thought, okay, well, if this is the pattern of results you're getting, let's try and find out what people think about the way that this intervention, the simple, inexpensive, seemingly clinically relevant intervention, was introduced. And at that time was based in London. So together with a large team of colleagues, so surgeons and anesthetists and psychologists like myself and others, and managers, we designed a study where essentially we did a very large qualitative study because we really wanted to understand people's opinions. And we went out to 10 different hospitals, and the hospitals were large and small, teaching hospitals and community hospitals, and they were stratified for size and the location in the country and everything else, as much as we could. And we got 2 rounds of interviews over a space of about a year and a half with 140, I think, or so individuals. So a very large study. Interview studies usually have 20, 30 people. And we interviewed so many people because we really wanted to understand clinicians, surgeons, anesthetists, nurses, ward nurses, managers who run surgical services. So some of the things that they said are on this slide. So basically, there was a large number of comments like this, which suggested to us that the way this seemingly simple, seemingly clinically useful intervention was basically introduced in a, what I would describe, in a haphazard manner. Like someone produced a piece of paper. What's the day today? It's the 5th of February, right? On Monday next week, guys, we're using it. I don't care how, we're just going to go off and use it. And if you do that, essentially with no plan, with no explanation, with no strategy about the implementation, clearly people were not happy. And they were telling us in the interviews that they were not happy. Of course, there were some examples which I don't have on this slide, but if you read the paper, you'll get the quotes. There was tons of quotes. We couldn't choose what to put in. There were so many. Some people said the chief executive of the hospital, the medical director, the nursing director, our own surgical anesthesia departments, we all got together. We thought about this. We supported it. We made it our own. We rebranded it. We put our hospital logos on all over it. So people knew it was our own. We changed it for our own speciality because the idea was that if you're doing major GI procedures or if you're doing eye surgery, you're not going to have the same risks and you don't want to ask the same questions. So you had the ability to tailor what was on that checklist and so on. So some people did all of that. But clearly you have a picture here of some hospitals where not much happened other than let's just go off and do it. And when that does happen, when that happened on this occasion, the results were clearly people being unhappy. So the reason I'm going on about the checklist is, first of all, that's just it's to show you how I got into all this all these years ago, but also because a checklist is a great case example, I find, because a checklist is a simple thing. It's one piece of paper. You know exactly that it all needs to be done within a space of a few minutes. It takes seconds to do it because we have timed it. On some occasions, take less than a minute for an uncomplicated routine procedure. It's not a very difficult intervention. It's not like sometimes, I work with interventions for mental health. I work with interventions, people type 1 or type 2 diabetes and psychoeducation. These are complex things which you need to deliver over weeks on teams, on individuals, or a mixture of the two. They have to do homework at home. This is not like that. This is simple. And even with a simple intervention, we have this consistent failure, and it's not just a checklist. It's a lot of things that happen in healthcare where basically we're wasting money, talent, and effort and energy. So if you look at these general assessments of how healthcare is integrating innovation into our practice, and these assessments and evidence, clinical evidence into our practice, on the back of the so-called evidence-based medicine movement that started in the 70s, and some of the findings are really shocking, because if you look at some of the headline findings, people are saying we're wasting huge amounts because we have tons of patients, approximately half of them, they're not receiving care that is up to the most to the latest standard. And a lot of the spending, like we especially in some healthcare systems, the United States unfortunately comes to mind when it comes to this, but it's not the only system where there's a lot of unnecessary testing going on. So we're wasting resources. It's costing us a lot of money. The patients get it, but do they really need it? They don't. And yet we fail to stop doing things that do not add value to patient care. And the money is staggering. The vast amounts of money that we're talking about here, which we could use to do far more things, to reach out to more people and so on. So we have an issue of practicing medicine or delivering healthcare beyond medicine, that it isn't really following best practice. So, and of course, the question is, if that's the scale of the problem, how do we deal with it? And in fact, these guys, years ago now, they took a view of how long it takes when you have an intervention that has randomized evidence behind it, that's been in reviews, systematic reviews and meta-analysis, there's guidelines. How long does it take for these type of interventions to be applied routinely to patient care? And they found that on average, it takes 17 years, which is very long. So if you take a combination of these findings and you look at it together, we're doing unnecessary things and we fail to do the necessary things because the rate of translating evidence or the speed of translating evidence is very slow. So of course, this is an average. And I would very much invite all of you to think about what is the intervention, the tool, or the pathway that in your experience, in your professional careers, really got translated pretty quickly. When the evidence became available, we changed our practice. And what, in contrast, perhaps, what are the interventions that even though we have tons of evidence, we don't seem to be able to implement in a way that is sustainable and scalable. So this is an average, but it makes us think that perhaps we could be much faster in healthcare in translating evidence to practice. And this is where the science of implementation came up. So essentially, it was a bunch of people around 2005, 2006 got together, and they were fed up with the fact that we keep producing evidence, we keep designing really high quality trials, global trials, with really huge patient numbers, well-powered studies, and then we don't use the result. And why is that the case? We need to do something. So the aim of the field, which was launched, we sort of take 2006 as a sort of the starting year, because in 2006 there was the first journal, peer-reviewed academic journal, that's called Implementation Science, and it's fully open access. So if you go online now, as I talk, you'll see what the journal publishes. It's been around for almost 20 years now. So there was a bunch of people that came together. They defined this field in very broad terms. Essentially, they defined the science as the science that studies and develops methods that promote the uptake of research into routine healthcare. And it could be the organization of healthcare, so healthcare pathways, could be healthcare policies and guidelines, or it could be the daily delivery of healthcare interventions. And from North America, because the funders eventually got interested in this, so the National Institute of Health, which is one of the largest funders of health care research internationally, it's based in the US, defines the science of implementation in a more descriptive manner. So it talks about a science that supports innovation in identifying, understanding, and overcoming barriers to adopting, adapting, sustaining of evidence-based intervention. So it's all about how you get evidence into, how you mobilize evidence into practice sustainably. And then, of course, if you do that, I would argue, of course, as a psychologist, that we need to understand human behavior. So you need people who understand human behavior. Indeed, you need people who understand how humans function and behave within the organizational constraints of a primary care facility, of a hospital facility, of a tertiary care facility. So essentially, behavioral science, broadly defined, as a study of understanding, predicting, and influencing human behavior. How do we help people do the right thing? How do we influence behavior in the direction that we want? Pretty much in the same way that we try to influence patients' behavior and populations' behavior to eat more healthily, to exercise more, to not smoke so much, to not drink so much alcohol. The same principles in many ways can be applied to how we can influence healthcare providers to help the uptake of evidence interventions into their routine practice. So this is where the field sort of started from. So just to clarify, essentially, there's two things that we're looking at here. There was the stuff that everybody was doing before anybody thought about implementation science, which is actual implementation. That's the doing. Like there's interventions, you develop care pathways, you deliver care day in, day out. There's a bunch of activities, there's a bunch of things that you do when a new guideline comes out, which means that your department or your patients actually receive what the guideline suggests. So there's the implementation, the practice or the behavior of implementation. Essentially, what we do, like what I do, is to study that process. So I want to understand, I want to observe and understand what the barriers or the drivers may be to introducing those implementation activities, to introducing those behaviors, and then perhaps intervene. And I'll show you how we intervene in a second. So essentially, you've got implementation and research that are separated, and that's the implementation gap. Implementation science is that bridge that comes in the middle and tries to bridge the gap. So we practice more based on the evidence. That's essentially what we do. So if you think about where implementation research sits, think about from basic research all the way to applied research. Basic research starts at the bottom of this slide. You wonder, is there a relationship? Is there a need for a new intervention? And then you start, if you look at sort of clinical journals, they often publish a safety trial or so-called drug trials and phase 1 trial. Then you go on efficacy studies. So can something work? Can an intervention work, a drug or otherwise? Then you go on larger scale, real world effectiveness studies, which answer the question, does this intervention or this program work in real life? Not when we optimize the conditions. Implementation studies come at the very end of that process, where you ask the question, what makes this effective program implementable in real life? So what does it take to put it into practice in a routine setting outside the research and development sort of pathway? So there are 2 or 3 things I want to go through in the next few minutes, because these are the key building blocks of the science. These are the things that you will find if you go on Implementation Science Journal. These are the sort of things you'll find in the titles or the abstracts of the papers that you will read. The first thing is the context of implementation. Essentially, by context, we mean everything and anything that is outside the intervention of the program that you wish to implement. You've got a new guideline for maternal care or for what you do when someone appears in A&E and you go through a triage process. What are the factors that will impact how that guideline gets implemented? That's external to the guideline. It could be how busy you are, if you've read the guideline, if how sick the patients all around are, how many people you've got on the ground in your A&E. All of this stuff is external to the actual what you're trying to implement. This is meant to be context. So your financial situation, all of that, political situation, whatever you can think of that is outside the intervention's context. The reason this is important is because if we take the view that, and I'll show you how to do it in a second, based on that analysis, you select the strategies that you could use to facilitate implementation, because your context and my context might be very different. So the strategies are basically methods or techniques or interventions that you can use to enhance implementation, uptake, sustainability of a program. So you choose them based on the context that you've identified, and then you go, yeah, and how do I actually do that? And here's where a bit of theoretical work comes in, because social and behavioral science is important for implementation. So essentially, there's a theory out here that tells you about how people will behave within the constraints of a healthcare system. So we use this theory to generate some predictions as to, if you do this that way, you're very unlikely to see a shift in human behavior. They're not going to use it. So you need to make it, you need to take a different pathway and so on. And that's really what we do in implementation research centers like ours in Singapore and a few others in the world. So I'll show you in a second now how these things come together. So this is an example of what the evidence base is at the moment in terms of what you might do to change the behavior of clinicians so that they can support evidence-based care more in their practices. So this paper was published. It's basically a big systematic review of the literature and then an expert consensus, whereby essentially there were 73 different behavior change strategies that were found in the healthcare literature. They were grouped in different categories. So there were things like, for example, the light green stakeholder relationships, develop these relationships. So don't just go and give people a piece of paper and tell them to use it. Run some workshops, understand what they care about, what the workload is like. So engage with them. So there's a whole bunch of things you can do to engage. Likewise, engage with patients, because patients have a voice, patients care about their care and the care of their loved ones and their families, their kids and their parents. Engage with the patients, because the patients can advocate for themselves. That's another bunch of strategies. Adaptation and tailoring. If someone produces an intervention, I give it to you, and the intervention is written in Chinese, you're not going to be able to use it very much. So the whole point is adapt the language, adapt the context, adapt the way you deliver it, adapt the things that would facilitate the uptake, and so on. So this basically, there's pieces of work like this that we now use to try and figure out which ones of those several interventions that, or implementation strategies, as they call them in this paper, which ones we might use to facilitate uptake of some of the interventions that we're looking at. And here's another example. This is a really nice review where basically people summarize the evidence in a way, or in a meta-analysis, randomized trial level evidence of what helps change provider behavior, physician, nurse, allied health practitioner. So these are the sort of things that you are basically looking to use to shift behavior towards more evidence-based practice. These are the sort of things that I use in our studies. So education, of course, education is absolutely important. Educational meetings, educational outreach, educational materials, a lot of ways to deliver education as and when you need it for your program, but also developing opinion leaders. So having opinion leaders who will advocate for the use of an evidence intervention. Audit and feedback has a huge evidence base behind it. So monitor behavior, provide feedback to me. So you show, you know what, Nick, your patients have an extra X rate of postoperative infections, whereas in your department, the average is much lower. What is going on? So I do not know that. Until I know that, I cannot adjust my behavior. You need to give me feedback, and then you monitor my adjustment over time. This is the crux of it. And it's one of the strongest behavior change interventions we found, offering reminders and so on. So these are the sort of interventions that you find in the literature. These are the sort of things that we put through trials to try and develop an evidence base for your use, so you can then support behavior change when it comes to putting these guidelines into practice. Here is an example, just to go back to what I mentioned earlier. I showed you what problems people had in implementing the WHO checklist. That was in England. We then did a review of all low and middle income countries that we could find any evidence on, just low and middle income countries. We looked at that checklist and we mapped, remember those 73 implementation strategies that I showed you? We mapped all of the strategies that all of these studies had actually used. So essentially, what we've seen on this slide, because we wanted to figure out which ones seem to be more typically used and also which ones are more effective. So for example, what you find in this slide, if you look in the middle, this yellow mustardy color is basically training and education. A lot of people are doing training and education. And the bit in purple on the left is about stakeholder relationships. So essentially, most people are using some sort of combination of training and then engaging people and developing their opinions, understanding their concerns, and engaging in dialogue to get implementation to happen. So these sort of studies give you an idea of what you might do. There are some strategies that no one ever uses, and we don't know whether this is because they're not effective or because they cannot be applied, or because people haven't really looked at the implementation literature. I think a lot of people repeat the same things over and over. I think there's an opportunity here to do some novel things when it comes to behavior change. Likewise, we then took a wider lens and said, forget about the checklist. Let's look at more complex interventions, any intervention that would include, that would aim to improve surgical or perioperative, more broadly, outcomes. So we looked at quality improvement interventions in perioperative care, and then we did the exact same mapping. And again, you have a sort of a similar diagram emerging. Interestingly enough, there's quite a lot of evaluation work going on in some studies. So that's the far left. So that's the sort of greenish blue. So a lot of evaluation and iteration, which is trial and error type of thing. We tried something, didn't work. We tried something else, that sort of thing. We provided some data. The green bit is adaptation and tailoring. And again, you see some of that. So you see that in the global evidence, because again, this was a global review, in the global evidence, in perioperative improvements, a wide range of strategies used, of course, alongside training and education and stakeholder work. So these are the sort of things where most of the literature seems to be going for, but of course there are others. But there are ways to map out what people have done so far. So we don't need to rediscover the wheel every time. Now, how do we go about? We've done these studies, and I can show you descriptively what people used and what effects they found. But how do you choose? There are so many strategies out there. How do you choose what you might select and to implement to change provider behavior? So they prescribe antibiotics on time. So they do the ID checks when before they operate on someone on time, and they double check and so on. Essentially, the process is this. You start with a theory, because we know people are people. We know the hardware we all carry is quite similar. Obviously, the culture, the language, and the context is different. But we all have, essentially, we're all human. So there are theories about how humans behave within organizations, like healthcare organizations. So we take that as a starting point. Then we use that to do what I suggested to use, the analysis of the context, whatever is external to your intervention. And then that lets you identify the challenges for implementation, the barriers. Then you pick implementation, behavior change strategies that address each one of those barriers that you found, and then you apply the strategies. That's the optimization process. So you spend some time to try and understand where the intervention is going to hit, and then you try and improve that journey. And this isn't really all mine. There's people who've been saying this since 1950s. Good theories are there for you because they summarize a lot of human knowledge in 1 or 2 or 3 slides. So in theory, don't be wary of theory. Don't be anxious about theory. Theories are useful because you cut to the chase without having to do a huge amount of feasibility work. Here's a great theory that we know works for healthcare providers. The theory is very simple. It basically says, if you want someone to show a behavior, to prescribe antibiotics differently, more of that or less of that or whatever, or to do a double check before they administer medication, they have to have 3 factors in place. There's 3 things that they need. They need the capability, so they need skills, they need resources, time, the money. You can't just, if they're under too much pressure, they haven't got capability. They also need the motivation. They need to believe that double checking is important, safety is important, this is part of their role and all that. Finally, they need to have a chance. They need to have an opportunity. Like, they need to have a chance to actually do the double check. Like, how am I going to do a double check if I'm the only nurse on shift? Who am I going to double check with? No one. So if you have these 3 elements in place, you're much more likely to observe the desired behavior. In our case, I'm just making up an example that is about double checking medication before you administer it. So this is a theory that's been shown to work in so many contexts, and it's a really useful way to think about where the gaps might be in your system or in your hospital, in your department, as to why people may not engage with a particular intervention. They might be lacking one of those 3 ingredients. Here is another one. Here, you use this one to analyze what I said is the context. So essentially, the context is everything that's around your intervention. And let's say you work, let's say you work with elderly people, you're in geriatric service. These people are at the huge risk of falls, and you really want to put in a checklist to predict essentially who is at a higher risk, and therefore you do something about them. Typically, nurses do those, but in your case, no one's doing it. People are falling over, they're breaking their hips, and it's a disaster. Essentially, you ask people, you observe them, or you sit them down, you do an interview, you do a focus group, and you basically ask them about 5 different things. First, what is the actual object, what it is that you think they should be implementing. So that's the characteristics of your intervention. In this case, it could be a false checklist for elderly patients. The inner setting means the local setting. What's the service like? Are they busy? How many people do they have? How many staff do they have? How many patients are coming in and out of their service? Have they got enough nurses and so on? That's the local setup. And then number three is the wider setup. What's the hospital like? How important is this improvement in the number of falls in your elderly patients that you get that you want to improve? Maybe you've got another priority. Maybe there's a national priority about falls. Like in England, there was one several years ago. And then there was another one on infection. Now there's one on mental health. Now we're talking about dementia. Every few years, every country and every system has some priorities. If you go with the priority, you've got a better chance of seeing a change. Number four, the people. Do you have the right people involved? Have you got the right opinion leaders? Remember what I was talking to you about earlier. Who are the people involved in implementing? And finally, the process. Is there a clear process? Does it fit with the work patterns and all that? So essentially, here's a nice framework that people have developed. You do this qualitatively, so you can interview people, you do focus groups, and then you pull the information together, and then you identify in which one of these 5 areas you might have barriers. And then you address the barriers using the strategies that I showed you. Here is one that we've used that's a bit more action-driven. So you say, I know my barriers and everything else, and I want to take some action. I want to start doing some stuff. So you start at 6 o'clock, which is the bottom. So the triangle in the middle is basically the research process. The research has developed whatever intervention you're now able to use. You start at 6 o'clock, and then you go clockwise. So you basically, that's where it's so-called action cycle of this framework that's called knowledge to action. That's what that is. So you go, what do I need to implement? Okay, do I need to adapt it? And I can tell you now, I work in Asia, the first question we always get is, this study was done in Canada. How applicable is this in Southeast Asia? And the answer is, I need to check because I do not know. For some studies, this will be really critical, or for some interventions. You then assess the barriers, as I just showed you. So you go and interview people, you do focus groups, or you observe them when they're at work. Then you decide how you might adapt or tailor the intervention. You change the language, you change the format. You make it paper and pencil rather than electronic because you don't want to use electronic because the system is down or whatever, or the other way around. And then you implement it, and then you see the arrows go in both directions. You implement and you monitor what on earth is going on. Are they using it? Are they not? So you evaluate the outcome. So because you might implement and then the first month it's all happening, and then when you stop and you go on holiday, you look at another project, the implementation goes back down. That means that you haven't addressed the barrier, something's going on. So essentially we're doing all this with a view to sustainability. So you implement for months and years for some of the things that need to truly change practice. So this is a more action-driven framework, but essentially the frameworks are to be used in conjunction with each other because some of them are good at identifying barriers and others are good at essentially driving behavior change. The sort of things that you can measure, and I have this here as a resource for you, I'm not going to go through it. If you want to look at implementation, there's certain outcome measures that you can use, and some of these have been developed and validated. There's scales, like you have patient-reported outcome and experience measures. You have implementation validated scales. We've summarized some of this in my previous job. So we produced a library, which is searchable. So if you want to know how to measure acceptability, how to measure feasibility, how to measure adoption, which is the intention to use an intervention and so on, we've got, there's not a huge amount of scales, but there's quite a few scales which you might pick. Then you might want to culturally and linguistically adapt to use in your own clinics, in your own settings. But I would certainly say have a quick look. It's all free. It's all there and it's searchable. So you don't have to discover something if it already exists. So some of this work's already been done. So I'm coming to an end, and essentially this is a really nice paper. It's a bit of bedtime reading. It's a very short paper that some American colleagues wrote a few years ago, essentially saying, here are some examples of projects, and they're mostly American projects, of how the projects benefited from using an implementation science approach, because they explain what was done and essentially how this impacted positively on the uptake of these innovations. So essentially, I'm just giving you a very high-level view in half an hour of a new field. What are the key concepts, some of the key methods, and some of the language that we use to describe how clinical interventions might make it into routine practice. Remember, when you do implementation work, the focus is as much on patients as much as on yourselves, on providers and managers. So the participants in my research tend to be doctors and nurses. They're not the patients, because we know more about the patients than we know about the providers. And of course, there's a big and evolving large field of health research that can be applied across intervention. So it doesn't really matter which area you work. you might learn things from other subspecialties or specialities. So it is a new field and it's growing pretty quickly. So I would say keep an eye out there, and hopefully some of that stuff makes sense. But very keen. I know there's a few points in the chat which I haven't been able to check because I'm just looking at my slides. But hopefully we have now 15 minutes to go through sort of your reflections to what you think about these materials. Tonya, back to you.
Yeah, thank you so much, Nick. So I'm going to ask the first question, and thank you so much for this very cerebral lecture. It's so full of stuff. I don't think 45 minutes is really enough time, just like you said, to give us all of this. You just gave us a lot of good stuff on implementation science. So my question is, what's the relationship between implementation science and improvement science? Because I think I saw improvement science come up in your slides once. Yes.
Yeah, so I think it's actually what a brilliant question. We get it so much, so we actually wrote a paper about this a couple of years ago with some
sorry,
colleagues.
Nick, we can't hear you.
Ooh. Can you hear me now?
Can you hear me? Yeah, it's okay now.
Yes, I can. All right.
Yeah.
Sorry, maybe my network. So I was just saying that this comes up so often. We actually wrote a paper about this some years ago. If you think about it, improvement science came out of manufacturing. So it came from a different place. It came with a very specific quest, which is not necessarily originally, it wasn't scientific. It was just about improving a process to get a better, a more reliable outcome because it had this manufacturing sort of background. It became so continuous quality improvement came out from that process and continues to be that process. At some point, about 20, 25 years ago, people got involved and made a science out of it. So they started scientifically doing large-scale randomized trials to test out improvement interventions and so on. And then 15 years later, implementation scientists came about and said, right, this is all great, but we need to study the implementation process a bit more. So there's a lot of similarities in the objective. The objective is to improve a process of care and therefore to improve an outcome. The methodologies are slightly different, but in my view, very complementary. So, for example, the plan, do, study, act cycle that you would have in an improvement project is an implementation strategy in the implementation literature, because you know that you need to do that trial and error and evaluate what you get before you finalize as you optimize your implementation. So the two speak a slightly different language, but essentially they're pretty much aligned. In my practice, I think I use both. On practical projects, I definitely use a bit of both because improvement science doesn't often think about sustainability, I find. So there's a lot of improvement work that you have a champion, like an improvement champion. As soon as they finish the project, they move on to another project. But what happens to what you've just done over the last year or so? Often you find implementation isn't really, the uptake falls. So I'm interested in developing sustainability implementation, sustained implementation as part of an improvement project rather than just identify the solution and then sort of run with it. But that's just one example of how the two complement each other. Essentially, we all meet improvement implementation journals publish very similar papers to some degree. So there's a really nice and healthy overlap between the disciplines.
Okay, thank you. So right now, there's no question. I know people are chewing on. Okay, so Dr. Kehinde Okunade he has a comment, okay, and a question. So he says, there seems to be many implementation frameworks. How can one determine the right fit? Sorry, yeah. So it says, there seems to be so many implementation frameworks. How can one determine the right framework or theory to adopt when designing an implementation research?
But brilliant question. There's about, it's probably we're reaching 200 frameworks at the moment. There's so many. So essentially, different frameworks are doing a slightly different jobs. So there's frameworks that help you find barriers and challenges and describe them. So that's one type of framework. There's frameworks that try to predict human behavior, like what would make one of your doctors, one of your nurses follow a guideline or not. And then there's frameworks that help you evaluate, like you've done a big study or you've done a big improvement project. How do you evaluate its implementation, the uptake, sustainability, how they deliver it as intended or not? So these are three categories of frameworks. And essentially, you pick the frameworks depending on your question. Is your question, what stops me from doing this? What stops people from implementing? Then you pick a framework that's really good at picking out barriers and drivers. If you really want to go through an action cycle, you pick up a sort of the so-called implementation process framework, which is like the knowledge to action that I showed you. So you cherry pick the frameworks depending on what you're trying to achieve in your project or in a context of a study. And my very practical advice is there's a lot of implementation people around, a lot of the people who wrote those frameworks. So I would definitely say, send them an email and say, these are the aims of my projects. Which framework would you advise me to use? And people would normally be very happy to say, use this, don't use that. I mean, I do that quite often when people approach me. We do not know all of them ourselves because there's so many, but we can give you a broad direction as to the nature of framework that might do the job.
Okay, then one question before our director asks. So Dr. Wosu is saying, thank you for your lecture. And in your opinion, as an implementation scientist, which strategies should be key in mitigating the effects of the next pandemic using lessons learned from COVID-19?
And again, what a great question. So I think depending on the context in which you're in, and here the context could be country or it could be the whole world, you think about what's my delivery mechanism, what's my capacity as a system, what's my finances, can I isolate people, what is people's perceptions of individual what's the right word? My right to go and move about. Like, for example, there's a very different approach to the government advice when I was living in England compared to the approach to government advice now that I live in Singapore. In Singapore, the level of trust in the government, I look at the surveys, is higher than what it was in Western Europe. Therefore, when the government advises something, people tend to follow, where in England, they followed a bit less. So you've got these factors to consider. So I would suggest that you look at it definitely at the level of a country, possibly bigger than that, but I would certainly say the context here is the country. And then you look at the contextual factors that helped or hindered the response to COVID. Did you have the measurement? Did you have the tracing? Do you know where the people are so you can reach them out and so on? And then you design the response to match that. Because what we might be doing in Singapore now in the next pandemic might be very different to what you might do in Nigeria because of the size, because of the networks, the human networks and physical networks and transport networks and IT networks and whatever else. So you can't, I don't think you can generalize across, but I would definitely say you could use a framework to say, what are my delivery channels? What were the challenges? And then you map on the back of that what you need to be doing differently. And again, I would go on forever about this. Frameworks are useful because they remind us the things that are important and we might just skip because something went really well. And I don't know how you guys responded when the COVID guidance was coming out. Do people follow the guidance or not? If they didn't, then we need to look at behavioral frameworks and look at behavior change, or why it is that they didn't, because perhaps they couldn't. So we found that in certain countries, people who could not stay at home because their livelihoods were basically wiped out and they couldn't provide for their families, they were going against the guidance because there was nothing else to do. So that is not a behavior change problem. Is we need to change what people can afford to do so that a public health advisory can actually be implemented. So we need all these multiple lenses at multiple levels, I suggest, and just pick one of those preparedness frameworks, as people call them, and then run through it and say where the country was. I definitely suggest, in my experience, is country level. And then you look at individual communities within your country, and then you find more differences. But I would definitely suggest start from country and work sort of downwards. That's a brilliant question. I think we need to do more of that because in many ways, COVID found us unprepared for the scale and the duration of the problem. That's a really good question.
Yeah, thank you. So I'm going to hand over to the director for Ivan Research Institute.
Tonya, go ahead with all the questions. I'll take the last question.
Oh, okay. So let's go to there's some more questions on the Q&A. Someone is asking for implementation of a treatment guideline. How do you go about ensuring good implementation in an LMIC country?
So I would start, remember the step I said, let's study the context. So I would bring together, let's find a guideline, maybe it's how you do rehabilitation after stroke, whatever it is, or how do you ensure better maternal outcomes during live sort of non-surgical sort of birth. I would take a guideline, whatever guideline you think is most appropriate, and I would create a small group of people who are the people who will be delivering the guideline, but also the people on the receiving end. So, like mothers or people who have had strokes and their families, you sit them around the table and then you go, how much of this is relevant to us? How much of this isn't? So you decide what is relevant and may need adaptation, or you need to discard because it doesn't apply to you. And then you work out an implementation plan for you or for your hospital, because large country, you have different hospitals, different needs. So I would go through this process of deciding what is relevant from a contextual point of view, and then designing an implementation plan. I wouldn't just say, here's a guideline, came from Northeast England trials, we do it, because you're not in Northeast England. So and likewise, it could come up from another part of the continent. Like you study the context in which you put it, and I definitely say you do it with people. So that would be my advice.
Okay. Okay. So Dr. Ijoma is asking this question: that do you think that the 73 implementation strategies you shared are exhaustive?
Well, they were meant to be as part of that study, but of course we know that depending on how you analyze human behavior, these may be 73, other people might find 50, other people might find 173. I think there's a lot of stuff in there, because 73 is quite, if you go through it, it's quite a lot. Most people find that list very lengthy. But I would suggest to you, I would hypothesize, if you've ever tried to introduce an intervention, even without doing a study, in your service, you would be using some of that even without calling this an implementation strategy. So some of it, a lot of it is hopefully intuitive. So then look at the rest of them. So it may not be, I don't think it's exhaustive, because I think we need to do more research on it. But I think a lot of it, you can see how much of it is intuitive and how much is things that you wouldn't have thought, but actually now that you read it and you look at the study that suggests that this is relevant, it might make sense to you. So I would keep an open mind as to how you choose those strategies and how many you need, because you might need 10 of these or 20 of these to make sure that your implementation is optimized.
Okay, so Dr. Stephanie is asking that in conducting the review of the implementation constructs being used in LMICs, did the authors find that the research team specified barriers to using certain constructs?
And the answer is some did. So we had quite significant variation in the studies. Some studies reported, we tried this and here are the barriers, and it listed the barriers. And the barriers went all the way from, we didn't have the rights, like the country was huge and we didn't have the right transport network. By the time we reached those guys, it was too late, or we couldn't get the patients in on time. So it was all sorts of things like that, to patient education, like patients refused to come to see a doctor because they went and they saw people who practice traditional healing practices in particular communities. And by the time they came to see the doctor was like, there's nothing we can do now because, it is too late. All the way to, in some countries, there were some real financial issues because the patient would have to bear the cost, for example, of some drugs, including antibiotics. And if the patient could not afford, they could not even be offered treatment. So then the barrier there is very fundamental, and it's before you even get into hospital care pathway. So yes, some studies did it very well. In other studies, we had to extract it and make an interpretation of what people suggested was going on, and everything in between. So, but there's more of this literature coming out. A lot of people are using global health sort of frameworks around, health system strengthening concepts, which essentially describe implementation processes at scale and sustainably and with sustainability. So that those frameworks seem quite similar to me to some of the frameworks they're using in implementation research.
All right. Okay, so in the absence of any other question here, I'll give the mic to the director for Ivan Research Institute, which houses the Center for Translation and Implementation Research. That's a training. So Professor Eche Ezanolu.
Hi, Nick. Thank you so much. Thank you so much for spending this time. I know what time it is in Singapore. Thank you so much. I have a comment and I have a question. So my comment was on the ERIC strategies, because one of the things I like about the ERIC strategies is the fact that those strategies are named, they are defined, and they are specified so that we can all speak the same language. Because like you said, what people call focus group they may not realize, or what people have been doing that is called focus group, they may not realize it's focus group, or what people have been doing. So some of these strategies, like you said, people use them without actually knowing that it's the same thing. So by naming, defining them and specifying them, we can all speak the same language. That way it allows us to communicate. So when I look at the ERIC strategy, what I like about it is actually the domain, because I think there's probably more than the 72, but looking at the 9 domains allows me to, if I think of a new strategy, to say what domain does it fit in, because that domain allows me to manage those informations and to be able to use them. So that's my comment on the. My question for you is, so when I try to talk about implementation science, I try to break them down into 4 areas like you were mentioning. So I think about looking at barriers and facilitators. Then I think about the intervention mapping, where I'm trying to say which intervention is going to work, the best to be used here. Then I'm going to implementation mapping, which is how do we implement it? All those things you're talking about, having an implementation plan. Then I think about an outcome evaluation. So my question is, when you think of things this way, and you know of all the multiple frameworks, is it prudent, and not one of them is really good for all of them? So when you are doing a project, do you have to use multiple frameworks? So one framework that is the best for determining barriers and facilitators, one framework that is good for outcome evaluation, one framework good for intervention mapping. How do you approach it?
And I think you've given that's a brilliant question, Prof. Etche. So I think you've given the answer there. You use different frameworks to achieve these different stages of an implementation and an impact evaluation. So you use one framework to identify your challenges and the barriers. You might use an approach,
is that right?
As
is that
you
the
said.
Right way to do it?
It is the right way to do it, in my opinion, because not all the frameworks are developed with the same motivation. So there's this consolidated framework that I showed you, the CIFR framework, is developed to capture barriers and drivers. It doesn't do anything else. It captures barriers and drivers. That's all it does. So if you want to capture barriers and drivers, it does a really good job at doing that. But it doesn't then tell you, now we've got that, what do we do next? And then that's why I'm using knowledge to action, because I've in fact used it in several I've used in several countries in sub-Saharan Africa, and people liked it because it was more action driven. Some people found CIFR very detailed. I was like, yeah, but we want to get to the action. So we use knowledge to action because people then started doing these adaptation cycles, and they were really happy to be doing hands-on work. And you're absolutely right. And outcome evaluation is a really cool framework. It's quite well known. There's a few others, but it's called REAIM. These are the sort of acronym, and the REAIM is what's used to do an outcome evaluation. So you've got REAIM stands for reach effectiveness, implementation. My brain's gone. Implementation. The last one is maintenance. Yes. Yeah. So if you do, essentially what that does is then you go, what is the outcome measure I have for reach? Like a denominator. You need the denominator of the 3,000 people. How many did you reach? So that's that. The effectiveness measure, you have perhaps a dedicated patient-reported outcome, but also a validated implementation scale. So you put that in there. Your maintenance, you look at, what happens 6 months post-intervention, 12 months post-intervention, 18 months. Is it sustainable? And so on. So these are the frameworks do different jobs. So I would expect 2 or 3 frameworks to be used in a very large program when you start for intervention, co-design, adaptation, all the way to evaluation. And I think that's perfectly fine. And I think it's important to communicate that with our colleagues. So people say, tell me one framework and I'll use it. And I'm like, you can't, because depends on your research question. So you can't, one framework will not usually give you an answer.
Thank you. Thank you so much.
You can definitely share the presentation. You can, I would PDF it because it's easier. And I would definitely put it across to all the delegates. And if you want to put it on your website, by all means.
So one thing that I usually try to ask, so I'm going to ask you this, feel free not to answer. So one of the things we get as a center, so we have the Nigerian Implementation Science Alliance and a practice-based research network in Nigeria. The practice-based research network involves sites in all the 6 regions of Nigeria. So we call them our implementation lab. There are 2 sites from all the regions. The idea was to use this implementation lab to try new things, new program adaptation, new guideline implementation, to see how it works before we scale them up. So that's the whole idea of the practice-based research network, being a large country so that selecting two from each side, we think we can account for some context variation and some cultural differences in the region. So so a lot of times we get people that are planning to implement projects and approach us, and we try to help them in terms of how to design it, how to plan for the implementation. My question to you, if we have those things, do you consult? Will you be able to help us if we bring it to look at them for us?
I mean, by all means, get in touch, and it'd be interesting to hear a bit more about the setup of your center, because we haven't really. This is the first time really we're meeting, so let's do that, and perhaps some of these projects we can consult on. We can, because I'd like to learn from what you're doing, the approach that you're using, and how you're engaging with these people, because I find that quite tricky. Sometimes people approach us late and they want some help, but it's so late in the implementation process, you're like, oh, I can't change it now because you're way down the road. So by all means, if you drop me an email, and Tonya has my email, my personal email, not the center email, then we can perhaps arrange a meeting and talk a bit more.
Thank you so much, Nick. Thank you so much for taking the time. Thank you.
No, thank you for inviting me. That's a great conversation we're having.
Thank you so much. So thank you, Nick. Thank you for honoring our invitation. And of course, we know that we'll engage with you more and more. Thank you so much. And thank you for offering to send in your slides as a PDF, because everybody's really enthusiastic to, go through your slides again. It was very, very enriching. So we've come to the end of the February webinar series. Thank you so much again, Nick. Thank you, everyone. Goodbye and good night. See you in March.
Thank you. Bye.
Bye.